I will try to distill this very complicated topic, antibody-drug conjugates in lung cancer, into kind of simple terms. So we won't sort of go too deep into any one concept, but I do look forward to your questions later if they come up. So first, during this talk, we're going to review the structure and function of what an antibody-drug conjugate is and how they're being applied in different subsets of lung cancer. First, in non-small cell lung cancer, which is the more common type of lung cancer, ADCs, I'm going to use the term ADCs for the antibody drug conjugate throughout the rest of this talk. They're being used in certain subsets of lung cancer for patients with certain genetic markers and in combination with standard chemo and immunotherapies. Secondly, Dr. Shields just alluded to this, ADCs in small cell lung cancer are making a huge impact over the past couple of years. So we'll review a little bit of that data. And lastly, we'll talk about some future directions. So let's start with what an ADC is. Dr. Shields sort of used this Trojan horse analogy. It's a complex drug molecule composed of three parts. The antibody targets a specific protein called an antigen on the cancer cell. So it's sort of sticking out of the cancer cell, ready to be sort of targeted by this antibody piece here. And it's linked by a linker to what is called the payload, or sometimes called the warhead. You'll see different words used for that, which basically means it's a very potent and toxic chemotherapy molecule. And they found that this drug delivery system can be used to actually to deliver much stronger and more potent chemotherapies than can be used in sort of their naked form without this sort of structure, because it would be too damaging to people's normal cells to just sort of use these very, very strong chemotherapies. But sort of cloaked as they are able to be delivered to people more safely and actually effectively. And the reason for that is that these molecules are not active until they're separated from the linker, and that only happens once they get to the tumor cell. So looking at that a little bit more closely, the way that this is arranged is that the molecule travels to the tumor cell through the bloodstream, where the antibody then attaches to that protein on the outside of the cell, as I said before, and then it's internalized into the cell. So it's sort of like sucked in, you can see into that little internal vacuole is what it's actually called, but it's just like a little pocket inside the cell. And inside that little pocket there, those chemotherapy molecules, those yellow things are separated from the molecule. You can see they're broken down here. So the molecules sort of taken apart. And then the toxic molecule here is able to get into the cell and damage it. So it's sort of like, it does its thing where it's really damaging the cell and ultimately can cause it to die. The cool thing about ADCs is that there's this effect called the bystander effect, where these little yellow molecules, these chemotherapy molecules here, can diffuse over to another cell even without the marker on the outside. So you can see that this other neighboring cell doesn't have a marker on it, but still was able to uptake these chemotherapy molecules and can still be killed. And so even if not every tumor cell has the marker on the outside, there still is the potential for killing the neighboring cells. This is just a figure, it's actually even a couple of years old now at this point, but this technology has really exploded over the past decade or so. This chart is showing you from 2011 to 2022, the development of ADCs across oncology. This is not lung cancer specific, but even just showing, you can see in 2021 and 2022, the really, explosion is really the word for it, of how much these agents have grown to show promise in oncology. And this is only increased over 2023 and 2024, which is not shown on this graph.